Hi guys, this is Dr. Patil and in today's video we will be discussing fibromyalgia. I know this is a small topic and in the past not many MCQs have appeared from this topic, but nonetheless it is going to become very important topic for the upcoming examination because now we know that we are anticipating 150 questions from general medicine itself and all these minor topics become important major topics in that case. Like probably you can't ignore any nook and corner of Harrison. Everything becomes important, but obviously we should know what to pick from those areas because some of those minor topics are such lengthy in the Harrison. One of those minor topics which is kind of lengthy in Harrison is this fibromyalgia. So I'll try to simplify it for your sake. Now let us understand what is the definition of fibromyalgia. Fibromyalgia is defined as a clinical syndrome characterized by diffuse pain, right? So I want you to pay attention to this word because some other definitions also use the wording called widespread pain. Widespread pain. So whenever the question, if there is a clinical question and it talks about patient coming with complaints of diffuse pain or widespread pain, you should consider fibromyalgia as one of the differential diagnoses. Okay, so definition goes like this. A clinical syndrome characterized by diffuse pain in the body including joints, muscles and spine. So that means pain can originate from any of these structures. So if patient is having joint pain, that doesn't rule out fibromyalgia. Fibromyalgia remains as an important differential diagnosis. Okay, and the last component of the definition is something that I want you to pay particular attention to. With no discernible evidence of inflammation at these sites. So if the patient is coming with joint pains, right, you're not expecting to find inflammatory signs on those affected joints, right? So you are not expecting to see swelling, tenderness and redness on those joints. Yeah, tenderness can be there, it is an important finding, but redness and swelling we are not anticipating, right? So if it is muscle pain that patient is complaining of, we are not anticipating raised CPK. Finding the signs of inflammation goes against the diagnosis of fibromyalgia, right? So this is the point to note. No evidence of inflammation. Okay. Now that is about the definition. Now coming to clinical features. Obviously the most common complaint is pain. Most common complaint is pain, and pain is widespread or diffuse. So the pain may be originating from the spine, from the muscles, from the joints or other soft tissues. Right? Pain can be originating from any of these structures. And remember, pain is very often described as multiple tender points on the body. So if there is a question talking about multiple tender points, right, again the examiner is talking about fibromyalgia. Okay, so this is something that we should know. Whenever the question is talking about multiple tender points, probably it is talking about fibromyalgia. Now apart from pain, there are various other associated symptoms and they are particularly important. From the treatment perspective, there are two important associated symptoms that one cannot afford to miss. The first one is fatigue. And the second associated symptom I want you to remember is non-restorative sleep. Non-restorative sleep. So does that make you think of any other disorder? Well, I would think of chronic fatigue syndrome in that case because this three combination is also seen in patients with chronic fatigue syndrome. So they also come with pain, yeah, but the pain is not the dominant complaint. Their dominant complaint would be fatigue. Fatigue, pain and non-restorative sleep, right? Apart from the fatigue and non-restorative sleep, these patients very often develop neuropsychiatric manifestations. So they are prone to develop depression and anxiety. So neuropsychiatric manifestations are known to occur. And also they are prone to develop irritable bowel syndrome. And if they are developing irritable bowel syndrome, it is the diarrhea predominant variant which is more common. Okay. Now talking about differential diagnosis, Harrison gives a long list of table, like lot of content there. But probably most of them are not important differential diagnosis because we can easily rule them out. Because we know that in case of fibromyalgia, there is no inflammation present, so we can easily rule them out. So according to me, the ones that come very close to fibromyalgia are hypothyroidism and hyperthyroidism. Those patients may experience similar symptoms. And the second thing that I would consider very, very close to fibromyalgia in terms of differential diagnosis is chronic fatigue syndrome, right? And we guys should know how to differentiate chronic fatigue syndrome from fibromyalgia. So there are no lab tests and all, but I will give you some important clues which will help you in clinical practice as well as in MCQs to differentiate between fibromyalgia and chronic fatigue syndrome. So the first point is, in case of chronic fatigue syndrome, fatigue is the dominant or predominant symptom. In case of fibromyalgia, it is the pain. They also have fatigue, but pain is what brings them to the hospital. In case of chronic fatigue syndrome, it is the fatigue that brings them to the OPD. Okay, that is the first point. And then second point I want you to note is that the onset of chronic fatigue syndrome is very often abrupt, and they may have a history of an antecedent viral infection, right? So they go through some febrile illness and then there will be an abrupt onset of the fatigue. So the onset is not so abrupt in case of fibromyalgia. Probably patient may not recollect any history of an antecedent viral illness, and probably he will not be able to pinpoint and tell precisely, like from these days or from this week of a particular month I started developing symptoms. But in case of chronic fatigue syndrome, it is kind of very, very abrupt. That is another finding. The third finding, which may not be very specific, but I do find it very useful in clinical practice, is that inflammatory markers like ESR and CRP are relatively raised in case of chronic fatigue syndrome in comparison to fibromyalgia. So these are the 3 points to look for. Okay. The endocrine disorders where fatigue is a symptom, obviously by doing the lab test, we can rule that out. Okay. So that was about the clinical features. Now coming to etiology, nothing well is understood about its etiology, but I still want you to remember some points. So far what we have found out is that in these patients, mainly in the descending nociceptive pathway, right? Majority of the abnormalities are from the descending nociceptive pathway or descending pain pathway. Descending nociceptive pathway. So in this pathway, what we have noticed is that the excitatory neurotransmitters like glutamate and substance P are increased. These are excitatory neurotransmitters and they are increased in descending nociceptive pathway. Thus, the pain perception is increased. Okay. So that is the first point. And then we have also noticed from the clinical studies that norepinephrine levels in this area and the serotonin levels in the neurons are decreased. So substance P is increased and glutamate is increased, norepinephrine and serotonin are decreased. I particularly want you to pay attention to substance P because in the clinical trials it is becoming an important test to differentiate between chronic fatigue syndrome and fibromyalgia. So in case of fibromyalgia, the substance P is increased. In case of chronic fatigue syndrome, it is normal. Right. We don't use it in clinical practice right now, but in the clinical trials, it is finding some use. Okay. Now the third point I want you to remember is there is decreased pain threshold. In the past, whatever MCQs have appeared from this, mainly from the PGI and some central institutes, were about this pain threshold. So they mentioned that which of the following is true or false regarding chronic fatigue syndrome, and they twist these wordings. So they say increased pain threshold or decreased pain threshold. So if it is decreased pain threshold, that is a true statement, right? The threshold or the level to which the pain can be tolerated is decreased, and minor nociceptive stimuli are thought to be the reason for this experiencing of pain. Okay. So remember this point. There is decreased pain threshold. And then the last observation from the studies is that they have impaired HPA axis response to stress, and thus they may have a little bit of low cortisol levels. Right? So these are the points to note from the etiology. Exact etiology is not known, but these are the abnormalities that we have come across from the studies. Okay. Now coming to its diagnosis, you guys may be very familiar with the older version of the diagnostics, and I know if you are following the latest edition of Harrison, you are aware of the latest guidelines also. But nonetheless, older version is still important because I have seen MCQs coming from this. So what we used to do in the older version is that there were defined 18 tender points on the body, predefined. So we have to examine at those points only. And if 11 out of those 18 tender points are positive, in the sense we are able to elicit tenderness in those 11 points, at least 11 points from the 18, then the diagnosis of fibromyalgia is established. That is the older criteria, right? 11 out of 18 tender points. So there are 9 tender points on each side, and if we get 11 score out of 18, then you can say there is fibromyalgia present. And to bring in objectivity to assessment, right? They may ask you to what extent or what should be the pressure exerted when we are eliciting tenderness, right? So the pressure exerted when we are eliciting tenderness is 4 kg. Basically what we do is we use our thumb and try to press on the tender sites, in the predetermined sites. When we are doing that, we are using our thumb. And how do we get to know that we are exerting 4 kg of pressure? The simplest answer to that is, if you notice that the nail bed is blanching, right? When you are putting pressure, if the nail bed is blanching, that means you're exerting the exact pressure that we wanted, right? Okay, so that is the older version, but then it required a little bit of complex. We should literally have a memory map of all those tender points and then examine it, or have a slide next to us about all those points where we should be examining and then examine. And patient's perception also was kind of subjective, so there were a lot of drawbacks with the approach, right? So to modify that, we have this latest criteria, not very latest, from 2016 we are using it. So ACR 2016 criteria is what we use for the classification of fibromyalgia now. So according to this criteria, there are 4 important points to be satisfied. So when all 4 are met, then only we call it as fibromyalgia. What are those 4 criteria? The very first one is there should be generalized pain in 4 out of 5 regions. So body is divided into 5 regions, and simple to remember: right upper region, left upper region, right lower region, left lower region, and the axial region or the trunk, right? So 5 regions. So if 4 out of the 5 regions are showing pain, first criteria satisfied. Okay, then the symptoms should be present at similar level for at least 3 months. That means if 3 months is an important point to note, and if the symptoms are improving or worsening, right, that doesn't go in favor of fibromyalgia. The symptoms should be roughly at the similar level. So 3 months back, whatever was the extent or severity of pain and the symptom, I experience the same severity of pain even today. They are not worse, they are not better. Well, that is exactly what we are looking at. And then to bring in objectivity, now we have this 2 indices called as widespread pain index and symptom severity score. So in the very beginning of the lesson, I told you that pain is one of the complaint and they have some associated symptoms. So we are assessing these 2 separately. We are assessing pain separately. For that, we are using this widespread pain index, and to assess the symptoms, other symptoms, associated symptoms, we are using this symptom severity score. Okay, the point is clear. So in case of widespread pain index more than or equal to 7 plus symptom severity score more than or equal to 5, that satisfied the criteria number 3. Or if the symptom severity score is more and the widespread pain index is little less, still it might satisfy. So in that case, WPI 4 to 6 plus symptom severity score more than or equal to 9, that also satisfies the criteria number 4. Now the last criteria number 4 is very, very important, and I want you to pay attention to that. What is the criteria number 4? The diagnosis of fibromyalgia holds good regardless of other diagnoses. If these criteria are satisfied, even if it is a case of say rheumatoid arthritis or any neurological disorder or any endocrine disorder, if these criteria are satisfied, right, the fibromyalgia diagnosis hold good. So for example, if it is a case of rheumatoid arthritis and fibromyalgia criteria are satisfied, you may say that this is a case of rheumatoid arthritis with fibromyalgia. Okay, so the diagnosis of fibromyalgia is consistent with the diagnosis of other entities. Okay, so both are applied. Then the last part of the statement is this: fibromyalgia diagnosis doesn't rule out other possible diagnoses. Right, so just because you have diagnosed fibromyalgia in a patient, that doesn't mean other rheumatological disorders or other similar symptom complexes cannot be occurring, right? So if criteria are met for other diagnosis, you can consider. So there is a one possible MCQ that can be asked from this, is that what is the most common diagnosis which is attached to fibromyalgia, right? So remember, 75% of the patients with chronic fatigue syndrome also satisfy the diagnostic criteria for fibromyalgia, right? So chronic fatigue syndrome is the most common diagnosis which is accompanying the diagnosis of fibromyalgia. Okay, now this is the diagnostic criteria. Now coming to those 2 areas I was talking about, widespread pain index and the symptom severity score. So in widespread pain index, obviously we are assessing the pain, and it is something that assessment is taken by the patient himself, right? So we give them a chart, or if the patient is not able to tick mark in the chart, maybe we can assist him. So from this scoring system, the maximum possible score is 90 and the minimum possible score is 1. So patient selects the areas and ticks wherever he is experiencing pain, and particularly note that when patient is asked to make entries, he is making entry based on his last 7 days of experience of pain. Right? So past 7 days is what is taken into account. Same thing holds good for the symptom severity score also. Right? So when we were talking about the diagnostic criteria, I told you that widespread pain index more than or equal to, remember from this point, more than or equal to 7 plus 5, right? More than or equal to 7 or 4 to 6 is the two ranges we had mentioned, right? So if it is more than 7, then the symptom severity score should be more than or equal to 5, and if it is between 4 to 6, then the symptom severity score should be more than or equal to 9. That satisfies the criteria number 3 according to 2016 ACR criteria. Okay, so this is the symptom severity score. What are the components included here? Fatigue is a component, weakening unrefreshed, that means non-restorative sleep, right? And cognitive symptoms and other symptoms like headache, abdominal pain and depression, these are taken into account. So in symptom severity score, basically the accompanied or associated symptoms are taken into account, and in widespread pain index, obviously pain. So one MCQ that is possible from this is they can ask you which of the following is not a component of symptom severity score for fibromyalgia, right? And that is like a ditch ground, because if you have not studied fibromyalgia, then you will think pain is an important thing and pain should have been a component, right? So you will not think pain as a component. You probably would answer depression, headache or abdominal pain as a component. It's not a component, right? But the truth is pain is not the component because we are assessing it separately. So the components of this include fatigue, right? Non-restorative sleep, cognitive symptoms, right? And when I talk about cognitive symptoms, I should also tell you that there is something called as fibrofog, right? There's a term called as fibrofog. That is nothing but description for fog, means like blurring, right? Blurring of senses or something like you can think of. So fibrofog is the cognitive symptoms that are experienced by fibromyalgia patients, right? That is why it's called as fibrofog. Okay. Then the other components include headache. Headache is a component of this scoring system. Then abdominal pain, and we also have depression, right? So I hope you got the point. Now that is about the symptom severity score. Now we know the diagnostic criteria. Let us talk about the management, right? So for management, we can follow the pharmacological treatment, and we also have some non-pharmacological treatment which also have some evidence backing their efficacy, because basically we are talking about a disorder where there is a limited role of inflammation and more to do with neurotransmitters and maybe some component from the neuropsychiatry, right? So the non-pharmacological treatment that are helpful include cognitive behavior therapy, graded exercises mainly focused on the aerobics, and various alternatives like Tai Chi, acupuncture, acupressure. All these are found to be helpful to some extent, right? Acupressure, all these are found to be helpful to some extent. Coming to pharmacological treatment, the American College of Rheumatology backs certain important pharmacological steps. NSAIDs, yes, they are useful to some extent to control the pain. So American College of Rheumatology particularly recommends weak opioids, mainly tramadol, and there is a reason behind that. So when we were discussing the etiology, I did tell you that in the nociceptive pathways, there is decreased serotonin and norepinephrine, right? There is decreased serotonin and norepinephrine. Tramadol, apart from being an opioid, it also blocks the reuptake of serotonin and norepinephrine, and thus it is additionally beneficial, right? So that is why there is a backing from the American College of Rheumatology for use of tramadol. Okay. Apart from that, yes, antidepressants can be used. So most commonly used antidepressant indeed is amitriptyline. We can also use fluoxetine. We can use gabapentin and pregabalin. And we can also use an SSRI called milnacipran. I particularly want you to remember 3 drugs: milnacipran, pregabalin, and fluoxetine. Like there is a reason behind that. These 3 are basically US FDA approved for treatment of fibromyalgia. Okay, so from these you guys already know fluoxetine is an SSRI and even milnacipran is an SSRI. It is also an SSRI. And to put little more into the practice, you can try to typify the patient and then use suitable drugs for them. For example, if pain is the bothersome complaint, right? So you can probably treat them with tramadol. Right? You can add one of the antidepressants, but you can probably treat them with tramadol. If the non-restorative sleep is a complaint, right, then you can use the antidepressants which have the sedative properties, right? For example, pregabalin. We know that it is a bothersome sedation that very often patients complain of, but these patients may be very happy with this drug, right? So that thus you can see what is the dominant symptom and what is bothering the patient more, and you can try to choose the drugs according to that. Okay, so that is about the treatment of fibromyalgia. So with that, we will wind up for today. In the next video, we will be discussing another important rheumatology topic. Thank you.